Hey there, it's This Week in Pharmacy. My name is Todd Urey. If you don't know me, welcome to the show. It's time to TWIRx. It is cold outside. Baby, it's cold outside. I don't know the words to that song, but this little snowman says it all. Burr. It's cold. I woke up this morning, I think it was 31 degrees in southwestern Pennsylvania. That is down in the Pittsburgh, Pennsylvania area. The Steelers lost to the Browns. It didn't make any sense. About halfway through the game, if you were watching the game, there was a blast of winter chill, and the snow came through and made things crazy and wacky. And my Steelers lost. So if there's any Browns fans out there, here's cheers to you. Here's some coffee in a warm cup, Pharmacy Podcast Network mug, and I'm going to take a little sip. That's all you guys get. That's all the congratulations I'm going to give you for the rest of the year. I don't like the Brownies. I don't like anybody in the AFC North except for the Pittsburgh Steelers. All right, we have a lot going on today. This Week in Pharmacy. We are finished with conference season for the year, which is wonderful in some ways, disappointing in other ways, because I really enjoy going to the conferences and spending time with the future of pharmacy, with the profession, with people that are out there doing it. And that's the whole reason for the Pharmacy 50 Awards. If you don't know about the Pharmacy 50 Awards, go to Google, put in hashtag Pharmacy 50 or just Pharmacy 50 Awards. We started this awards program in 2021, and this is to bring attention to people in our pharmacy profession that are standing out, that are working hard, that are doing things extraordinary people, influencers. And I believe in influence. Influence is like dominoes. Have you ever, and not the regular way of playing dominoes, but when you set them up, you stand them up, you press one, and all of a sudden they all fall, and it creates action. And that's every single one of the influential leaders in pharmacy since 2021, awards up until last year. The last year awards program was just enormous, but they've made a true impact to our profession, whether they were a student pharmacist, whether they were in community pharmacy. We always talk about where the votes are coming from a perspective of what sector of pharmacy that they're in. Go to pharmacy50.us. Once again, that's pharmacy50.us and cast your vote for the 50 most influential leaders in our profession. And we have a shout out to Mike Johnston from the NPTA, the National Pharmacy Technician Association. We have added pharmacy technicians as its standalone category this year because we know how important and how influential pharmacists are to our profession, backbone of the pharmacy industry, the right hand of how pharmacists rely on them and build upon them in so many of the sectors, and we need our pharmacy techs. So thank you, Mike, for making that suggestion. So many of you that won in 2023's awards have gone ahead and done some incredible things, and we're going to be doing a preview upcoming through TWIRx and This Week in Pharmacy of a couple of you, and we're going to invite some of you on for interviews to talk to us about what you did over the year in using your award to stand out and do more for your patients, the profession, for advocacy. This means a lot to us. I will give a shout out to the Reddit. You know me and Reddit. If you hear me complain about Reddit, but I'm real. I'm transparent. There was a post on Reddit, and if you go to the pharmacy section, put in the word influence or influential, how once again throwing it under the bus, saying how it was just a popularity contest, and it's those people that are keeping themselves from moving forward in what's happening. It's not easy to be in pharmacy. It's not easy to be us in pharmacy as a publication. The very first, imagine trying to make money in podcasting in 2009 through 2019. just to level up in order to keep the publication going. And it's because of the positivity, and it's because of people, it's because of our listeners, it's because of pharmacists that believe in advocating and pushing good messaging and good programming out. And now here we are, our 4th annual awards of the 50 most influential in pharmacy, and it is incredible. We have the assistance of RX Insider this year, which we're excited to be working with RX Insider, and a shout out to them for sponsoring the awards. And we will be talking about this for the rest of 2024 and into 2025. But once again, go to pharmacy50.us and cast your vote. All right, I do want to give a shout out to the APHA. They're igniting inspiration, ignite your inspiration in Nashville. If you are planning to go to the APHA 2025, please reach out to us, schedule some time with us, tell us what you're doing in the profession. Tell us if you need assistance in getting more attention around something that you're passionate about. I love, and it's my joy to put more emphasis on what pharmacists and what people in pharmacy are doing to really change the industry, to break away from some of the norms that have kept us hostage and kept us in place in standing still through our payment systems and things that are happening. It's been frustrating to go through what's happening in PBM reform. We're going to get into some news today. Just want to get into the news right now, TWIRx news, and want to start off with exactly that subject. And that is a article from Alan Goforth, and he works and writes for the benefitspro.com. They just put out an article just today that said rising prices, pharmacy closures raise concerns about access to medications. You know, remember I said about dominoes? The economy is a living, breathing thing in words, where if you make something happen 5 years ago in the economy, it will trickle and it will domino affect other things. And that's exactly what's happened with PBMs and the 3 biggest PBMs, and constantly sucking up more of the money in the form of profit and not putting it back into our staffing of pharmacy and technology and infrastructure. And this is causing major harm in our public health, in our nation's public health. A survey found that nearly 6 out of 10 Americans worry about obtaining medications close to home, and the increase of pharmacy deserts is prevalent. And I want you to read this article. Once again, it's benefitspro.com, and it goes through how this is happening, why this is happening, and the effect that it's going to have. Once again, domino effect coming. And I've said this before, and I'm a glass half full. I'm a very positive person, but I honestly think from the perspective of access and medication and having pharmacy care in your community, I think it's going to get worse before it gets better. However, the positivity is we do have some very strong, well-established and positioned independent community pharmacies out there, specialty pharmacies out there that are strong, our long-term care pharmacies that are strong, that are going to get us through this, as well as the associations. Shout out to the NCPA. We just got back from the NCPA's 2024. They are so aggressive. They're doing so much. A shout out to PUT, Pharmacists United for Truth and Transparency. They started their podcast with us, and they're leveling up. And Jeremy Counts, I've seen votes come through the Pharmacy 50 through for Jeremy, Dr. Jeremy Counts, and he is he's a champion, and the news continues to trickle in. We want to give a shout out to the Oklahoman magazine. It's at the oklahoman.com. And this article is titled, it says, Oklahoma County stepping in after state cuts funding for prescription medicine help. And this is written by Richard Mees with this magazine. And once again, it goes deep into how PBMs, 3 biggest ones, have caused issues that are now creating major issues for funding for, in this case, the smaller counties. The commissioners of the county voted to preserve the county pharmacy and save nearly 1 million prescriptions for nearly 7,500 people based on last year's figures, according to the main beneficiary nonprofit Health Alliance for the Uninsured. The commissioners shuffled funds from the American Rescue Plan Act to do so. And there's a quote that says, "This funding, combined with the federal purchasing power of our county pharmacy, will help thousands of people." This was Jennison Jones, executive director of the Alliance, which operates numerous free clinics. We're going to be seeing more of this throughout the country. Counties, states, government realizing that small governments realizing that they're going to have to step in and do it themselves. And it's great to see this. And I want to give a shout out to Accessia Health. They are helping Americans across the country get their medications paid for. And we've worked with them many times, especially at the conferences. Next, happy news. Enveda raises $130 million to advance AI-driven plant-based drug development. This is fascinating. $130 million to advance artificial intelligence-driven plant-based drug development. And this article comes out of the pharmaceutical-technology.com. Once again, that's pharmaceutical-technology.com. And it goes through the type of research that they're digging into, anti-inflammatory treatments. They're going to be digging into oncology disorders. They're going to continue to advance obesity and fibrosis, chronic pain, neurological disorders. But this is exciting. AI in the hands of pharmaceutical drug development. My favorite, the pharmacists. It's going to move us forward and do things that we've never been able to do before, and replicating science and replicating study, and taking that existing study and putting it into new studies, and being able to come out with advancements in drug therapy as well as digital therapeutics, and how that's going to become coupled with a pharmacist oversight. And we want to do more. We have a series coming out that will feature Click Therapeutics again. Shaheen, who is their CMO, he's brilliant, and they are advancing. So Click Therapeutics, digital therapeutics company, is doing more with tech, and they're saying, hey, we're finally able to show FDA how we're moving forward with technology as a prescription. And it's fascinating. And I'm thinking of P2s that are thinking, or if you're listening right now, you're a P3, you're a P2, you're young, you're thinking of pharmacy, think of tech, think of technology, of how it's going to advance medicine and therapy, and get into it. Start reading about it, even blog about it, or ask lots of questions. But I think that the future of pharmacy is going to look 100% different 5 years from now than what it is right now. And tech is going to be a big part of it. Hey, I want to turn to LinkedIn. LinkedIn's my favorite social media platform. The professionalism is still held high. You get shamed if you start putting out too many pictures of corgis or something, as much as I love corgis. But I want to give a shout out to Lanny Duong, PharmD, who's one of the co-founders of the Pharmacy Guild. And she posted something just recently on LinkedIn about some additional celebrations with the union. And it says pharmacists at CVS stores in Westerly in Middletown, Rhode Island, have voted yes to unionizing, can't say unionizing with the Pharmacy Guild. Pharmacy professionals are coming together for safer staffing, improved patient care, and better working conditions. And there's more. Middletown pharmacy techs just filed to unionize as well. Congratulations to both Rhode Island stores for this incredible win. Congratulations to the Pharmacy Guild. Can you imagine how hard it is to form a union with so many people poo-pooing the idea for years, And now it's finally making waves and it's finally actually taking hold in order to stand up to organizations that are not doing things the right way. And this just draws back to the PBMs and how CVS, in this case, there's two sides of CVS. There's the PBM and insurance side, and then there's, of course, the operations and where the heart of pharmacy is, which is to reference their logo, the red heart. And that red heart is not the PBM side. It's the pharmacist side. It's the pharmacy technician side. And that's the good side of CVS. That's the side that we want to see change and form unity. And so the Pharmacy Guild is doing things that have never been done before in our profession. And I'm just a big supporter of the entire organization and the people that are leading it, starting with Pizza is Not Working. Bled to Noe. I mean, she was frustrated. She wrote a blog, kicked off some social media, and here we are. And you know what that is? That is the aspect of, are you sitting on the sidelines or are you actually getting involved? Bled has a job. She has taxes to pay. She has family matters. She has a beautiful family, beautiful children. She has a husband. She's just as busy as the rest of us are. And she picked up the sword and she picked up the shield and she says, I'm going to stand for my profession. She got beat up. She got thrown under the bus. She was called names, but she stood. And what came out of that? Shane Jereminski and Lanny and the Doctor of Comedy, Murray Shaw, they formed the Pharmacy Guild. And now it's going to make waves. And remember, dominoes, the domino effect of the Pharmacy Guild is going to have massive, massive impact on our pharmacy profession. And I'm proud of what they're doing. And I'm proud of this coming, and it needed to happen. So shout out to Lanny. Thanks for posting this on LinkedIn. LinkedIn is probably one of my favorite sources of news. And if you're not connected with Lanny, just put in her name, Lannie, and then it's Duong. It's Duong. Shout out to you, Lanny. Hey, before we get into our first feature interview, Dr. Robin Barrett, Barrett, she's the CEO and founder of Refuel, and she's a content creator. She is a social media star. She's a pharmacist, and she's an entrepreneur. And I want to feature her for just a second and say something. She was attending the Ebony Power 100 Gala, and guess what? That meant that there was representation of pharmacists at the Ebony Power 100 Gala. And I think representation is important. If you're watching on YouTube, you see her in her gorgeous dress and in an outfit. She is a fashion mogul. She develops fashion. She was a Pharmacy 50 award winner in 2023. And she's just doing some crazy, incredible things with her fitness app and her Instagram following. The reason why and there's so many people that the negative people out there, once again, I've heard it on Reddit, that say how insignificant this is. And it's not. It's representation of our profession. It's representation of what a PharmD is doing in order to advocate and in order to show what pharmacists are capable of in shifting away from a traditional role and being able to have a background in pharmacy, but then apply that to health, to public outreach, to public health, and representation of what it is to be a pharmacist and how it can impact little girls that are watching her and being like, I want to be like Dr. Barrett someday. And maybe they go to pharmacy school and maybe they say, I want to do something more creative as a pharmacist. And I want to open up my imagination. So you have no idea, we have no idea what Robin is going to do for the future of pharmacy but we do know that she's going to make an impact. So I'm saying that to you because you might think if you write a book, if you do a children's book, or if you write poetry, or if you're creative with social media, or you stand up for some kind of passion that you have or advocacy or whatever, don't stop and you don't understand the impact that you could have on other people that are watching you, that are listening to you. And then the fact that you just happen to be a pharmacist just puts for me, it puts a cherry on top of it, because you're just superstars. You're out there doing things to better people's lives as pharmacists, keep them safe. But then you have a side gig that maybe it's a hobby, but it could turn into something huge. And guess what? Robin started out with a hobby. She has a podcast called The Dose, and I just think she's phenomenal. So that's just an example of how pharmacists can make an impact. Hey, we have a wonderful interview today. I'm not going to keep you from this anymore. Anthony is a friend. He's a champion over in New Jersey. He's a pharmacy owner. I want you to listen to this interview and understand that 2025 is the year of the pharmacist. I put that flag in the ground back in the summer. I know it's the year of the pharmacist. I know amazing things are going to happen in our profession, but we're going to be sweating terribly through that year. It's going to be a hard year. It's going to be a tough year, but it's going to happen. And we're going to make a huge shift in 2025 in setting the future of our profession and what that means for pharmacists, how you get paid, how you push forward, the advocacy that's building, the momentum that is building has never, ever. I entered pharmacy 20 years ago. It has never been stronger than it is right now. And I know that there's pharmacies closing, and there's a lot of people that even, get laid off from a job or something. I want you to know that we have connections. We have people like ShiftRx.com, and we have creativity like RX Post, and technology platforms like Outcomes. And there's just so much going on. IPC has been a great support of our community pharmacies, our independent community pharmacies. There is so much momentum right now, and I want you to believe in your profession. I know it doesn't seem that way right now. I know how you're feeling. Reach out to us. Let us know if we can ever make connections for you. And with that, let's go.
Hey, Todd, thanks for having me on, and thanks for your interest in what we're doing in 2025. As I'm exiting my presidential year of New Jersey Pharmacists Association, I can never let myself have too much time off or too much free time. So I'm starting to pack the agenda for 2025 already with some exciting stuff. Legislatively in New Jersey, we're working on a very exciting initiative that actually takes us back to the past a bit in pharmacy, which is the conversion or carve out of the Medicaid drug benefit, bringing it back to being administered by the state again, as opposed to the PBMs, or as we call them in New Jersey, MCO, which stands for Managed Care Organization, which gives pharmacists a whole new ability to map out and demonstrate how cost savings can occur absent a PBM, except for the PBM doing its administrative role. We've recently launched our long-term care at home initiative through CPESN, which I know you're familiar with them. Again, another great avenue for pharmacy for pharmacists, as we continue to make those inroads into more of the at-home model of care versus going away to an assisted living, or some sort of group rehabilitation setting. It combines telehealth with the ability to deliver certain services to the home, and it presents it opens up a whole new world of access to patients based on our ability to provide services versus just shipping medication in a box to somebody's home. That's something that's new that we're working on with CPESN, who's been a real leader in that sector of practice. We're also greatly expanding and getting aggressive with our direct to employer model for billing. And this builds on Kyle McCormick's model in Blueberry Pharmacy of the Cost Plus Drug Network. That's been popularized by Mark Cuban most recently. His model works a little bit differently. Essentially, it is a cost of medication plus an administrative fee, much like we see with the Cuban Cost Plus model. But what this does is it's going to go directly to small employers who are typically self-funded, meaning they're paying the cost for their drugs. So by going directly to a pharmacy and contracting with them, we can deliver substantial cost savings, cost certainty, higher levels of service, and more than anything else, we eliminate the dreaded spread pricing. And that's where the cost savings come in. We're working with some in the industry to develop an algorithm that will analyze an employer's current drug spend and demonstrate to them in real dollars what their savings would be if they went with, for instance, the Bell Pharmacy Clear Cost plan, which is what our term for our Cost Plus network. And the savings range anywhere from typically a low end of 35% all the way up to 75% based on the types of medications that we're dispensing. So it's really pulling us outside of that wait for prescriptions to walk in your front door that is just really becoming more and more challenging these days. Of course, we are always on the cannabis side at Camden Apothecary, looking at new avenues and new models where we're integrating the ability to move people from prescription medications over to attempting or trying a non-prescription alternative, a more natural remedy, typically, well, obviously in cannabis. And when we look at the, typically the pain medication, sleeping medication, anxiety, these are all opportunities to convert a patient from what is typically a more addictive prescription to a natural, holistic, nutraceutical, herbal, however you want to call it, remedy. And our model, which is being tested with a few professional sports organizations, we won't share those names as they've asked not to be shared so far, but working with retired athletes, and they're wrestling with a lot of symptoms that come along with their time and playing in sports, multiple concussions, all the bumps and bruises, and they're having a rough time of things on prescription medication. And can we make that better for them through cannabis? And of course, being pharmacists, we have the ability to really look at a patient's medical regimen and say, you know what, this is crazy. We do a little bit of a diagnostic and try to get their pharmaceuticals in order. And then we, of course, try to recommend alternatives in cannabis. And one of the big tools that we have in that is the endocannabinoid DNA test, which is essentially it's pharmacogenomics, but for cannabis.
Yeah.
Because we know that not everybody responds to cannabis the same way, just as we're learning more and more that there's much, much greater of a genetic component to response to pharmaceuticals. So there's a lot of exciting stuff that's happening. That's what we have so far in the run up to 2025. I'm sure by the time we get there, there'll be even more to share.
I have a question for you as a pharmacy owner, and somebody really is dialed into this. So data, it shows what it shows. I mean, and if you can't make anything of it, it's confusing. It's archaic. You have people like Antonio Chacha and his teams, and they've made crystal clear models where they can describe it to politicians who don't know what a PBM is, where they're using data, which is just facts. It's black and white. They're not putting any spin on it. And now all of a sudden, the policymakers are like, holy crap, all of this tax money that's supposed to be going to drug coverage is going to these things called PBMs, and it's profit. Like, it's what in the world's going on? So what I'd like to know from your perspective, 2024 coming to an end, but do you think when we look at a 5-year span, let's go 5 years into the future, 2029 or 2030, we could say, hey, we started seeing the decrease in prescriptions that were being processed by PBMs, and the money disappeared in the market, but we started tracking it some other way. I don't know how it's going to be tracked from a data perspective, where we have all these cash-based pharmacies popping up. We have all of this cash being spent on coaching, clinical services, remote patient monitoring that might have been coming out of a different fund. Maybe it's Medicaid, maybe it's Medicare Part D, who knows? But I can't wait to see that data that I keep saying on Twitter and on social media, on LinkedIn, 2025 is the year of the pharmacist. And what I mean by that is that's going to be the time period when we look back on the data that we're going to see the biggest shift in how pharmacy care was being paid for. And you're going to start seeing on the graphs that's where the deterioration for the traditional model of having things paid for started happening. It started trickling off. So you know as well as I do, with the greed that's out there, that those organizations are quickly scrambling and trying to figure out what's the next way where dispensing is it's going to start disappearing. It's going to always be there, but it's going to be just kind of a give out model. It'll just be like a cover fee, basic cover fee. But all the revenue that a community pharmacist, a specialty pharmacist, a pediatric specialist, a cannabis specialist, all the money you're going to make is going to be literally in the treatment, in the CPT code or the ICD-10 code or whatever that classifies what you just did as the pharmacological expert. So give me your opinion on all of, I know that was like a whole shoebox of stuff, but try to decipher that.
Well, you know what, Todd? I mean, I think that first, the big steps that we've made over the last year or so have been that elected officials, the public, they finally are starting to understand what PBM is. Before, it was 3 letters. Nobody had any idea. And if you try to explain it, their eyes will glaze over because it's so complicated. But people have now they understand PBM equals bad. And that's where increased costs are coming from. That's where the out of control prices are coming from. And as the PBMs have driven most of the independent pharmacies out of the business, you can't say, well, they just are more expensive because they're inefficient, because they can't compete, because of blah, 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 all these different reasons. Now it's mostly the chain pharmacies that are closing, which are also affiliated with the PBMs. Exactly. So what's happened is, all the market-based excuses for why pharmacies are closing are disappearing. And more the PBMs can't just say, well, they say that, but we still have 500,000 independent pharmacies. So really, is it that bad? And one of the emerging crises and when I say emerging, it's emerging only because it's now coming to the public consciousness, is the phenomenon of pharmacy deserts, which we've discussed several times over in small bites over time, because it's been happening. But it's not only an inner city problem or a rural problem anymore. It's now out in the suburbs. It's everywhere. Pharmacies are closing at an alarming rate, and nothing is replacing them. And that's where, when we talk about all those ancillary services that pharmacists would provide for free, that were typically supported by the markup that pharmacists would make on the prescription medications that they were dispensing, are now all dissipating. And you just have holes. And, when you've removed the most accessible and the least expensive component of the healthcare system, there's only one place to go when you get sick now, right to the emergency room. And that's exactly what they've been trying to avoid in the medical side of things for several years. So to take you back, when I started in pharmacy and, when I got out of pharmacy school in the 90s, the first thing all my friends would say to me would be, "You work where?" And I would say, "Camden, New Jersey." And they would go, "Oh, why would you do that? You can't make any money in an inner city, and it's poor. And how many widgets do you sell out front and all that?" I said, "No, we don't do any of that. We just fill prescriptions." And the secret that I knew that they didn't know was, while they were working out in the suburbs, dealing with employer-based, heavily concentrated patient bases that were all enrolled in PBMs, I never had to do a prior authorization. There were no formularies because Medicaid didn't have that. And it wasn't because Medicaid was unsophisticated. It's that the state health plan was still reimbursing under the traditional model that fueled the growth of pharmacy. And that growth of pharmacy resulted in broad access to the most trusted, most inexpensive healthcare resource, and that was the independent community pharmacist. And, you know, it wasn't funded by taxes, although I guess you could say it was funded by taxpayers because it is tax dollars that pays for Medicaid. But there was enough money in that it was able to fund and keep and motivate young entrepreneurs and young practitioners like myself to locate to the inner city, because I didn't have to deal with any of the PBM bullshit. Am I allowed to curse on a podcast, by the way?
You are. This is
fucking A. That's awesome.
This is an 18+ podcast out here.
All right. But seriously, so I came in and I invested, and there were others of my age that invested in taking over practices in the inner city because the margins were terrific, patient retention was high, and then all of a sudden the MCOs showed up, and once the state said, well, so we could give it to a PBM and then we don't have to administer it anymore. There's no more, we don't have to oversight and blah, blah, blah. You know, we don't have to oversight. We don't have to audit. We don't have to worry about checks. We don't have to worry about, we could just write a check to a PBM and it's their problem from here on out. That's when the bottom started to fall out, because once the PBMs became involved, and of course they had their own mail order pharmacies, Mrs. Smith, who would get 6 or 7 prescriptions every single month from us, is gone. One day she's here, one day she's not. And why? Everything comes from the mail order PBM. So we lose all that. The customers or the patients that we did retain, now all of a sudden, instead of getting AWP -5, getting AWP -15. Instead of getting a $5 or a $7 dispensing fee. And this is back in the 90s, $5 and $7. Now you're getting $2.50, $3.50. Now it's down to 75 cents. So, you know, that sort of, you know, obviously pharmacy is still product driven because there's no other model that allows us to be compensated any other way. So everything is driven on volume and how many prescriptions you can do and how much revenue you can draw. But there's no incentive as a business to do this anymore. Who would want to do that? You know, opening a pharmacy is expensive. You're looking at $1 million, $1.5 million out of your pocket. You dispense medications, Amerisource, McKesson, Cardinal, they get paid every 15 days. We get paid every 30 to 45 days. So you're carrying all of this cost. Plus you've got your student loans. What person would take that on instead of just taking the easy cash and going to a hospital or going to a chain? And what you saw was a whole generation that cared for communities between the years of 1920 to 1985. Little by little, they retired, they closed, they sold the chains. Now there's nothing. Camden City has 85,000 residents. We are down to under 10 pharmacies. There's only one chain. It's a Walgreens that's inside a local hospital. So I would argue it's not even really all that accessible to the public. There were probably quadruple that amount of pharmacies when I graduated. And what happens, these are your most vulnerable patients. Those are the ones that can't get appointments real easily. They don't have transportation. And they would walk into a pharmacy and say, I use this as a good example. I've had a sore throat. Can you sell me an antibiotic? Well, we know how to triage and find out whether or not they really need an antibiotic or whether or not it's just because they have too much dry heat in the house, and sometimes just moisturizing a little bit, some lifestyle changes, and something minor. Back then, you could still dispense, Rondec DM and things like that without having a problem where they took everything away. But we were often able to solve problems that patients would typically go directly to an emergency room for unnecessarily. And we did it for free. And that's gone. All that's gone. So now somebody has a sore throat, bang, emergency room. You know, somebody has a minor rash. Appointment is with a doctor's office or anywhere is weeks away, bang, emergency room. They know if they go to the emergency room, they're not going to pay. They get free transportation. So now the easiest thing is for the most vulnerable, rather than walking into their pharmacy, taking 15, 20 minutes and having the problem solved with no impact to the health system. Now, everybody, all there is emergency room visits now. Most of them can't even get to many of the urgent cares that are in the area because of transportation challenges. So when you remove the ability to reasonably sustain a business, and nobody will go into that any longer, the government can't force people to open pharmacies in the inner city. There's got to be an incentive. And when those incentives are gone, that's it. There's nothing. And that's why we're one of the very few that's been around, from when I was young, that's still here. But nobody's coming in behind me to do this. My stepdaughter graduated from pharmacy school. She doesn't want to do this. It's hard. It's not, the reimbursements are terrible. And if you do make 50 cents, the PBM is going to be showing up to audit you and take not only the 50 cents, but probably cost you $500 in legal fees fighting over that 50 cents. That's what we go through now. So in New Jersey, one of the things that we're working on is a return to a fee-for-service model. And basically what we would be looking at, and what the New Jersey legislature seems to be open-eared to, and by the way, this has been accomplished successfully in many other states, California being one, New York being one, with tremendous tax savings to the taxpayer, is a fee-for-service model. And rather, the PBMs can still have a role in processing, which, by the way, was the only thing that they were ever meant to do, was process. They were never meant to be in the pharmacy business. And Lena Khan, if you're listening, I will say again, it's time to prohibit PBMs from being in the business of pharmacy in any way, shape, or form. So I'll throw that out there again. Yeah. But with a $10 copay for a prescription, with reasonable reimbursements for product, the typically NACD plus 2% versus, the same thing minus 7%, or acquisition cost, or WAC as they call it, plus 0.75%. An actual average, a real barometer of an average acquisition cost for a product, plus a small markup. And what you will do is, all of a sudden, who wouldn't want to open up? Mm-hmm. That's why the chains came to the inner cities to begin with. There were no chains in Camden when I was first starting, but they figured out what I had figured out, which was, you make much more money dealing with a Medicaid benefit than you do with a privately insured patient. And they all came in, and they were instrumental in wiping out most of the older independents who couldn't adapt and compete. But then once they became victims to this failed financial model, they closed and left. And now the independent is gone, and they're gone. And there's nothing left in its wake. We've got to bring that back. And the only way that you can bring that back is through incentives. And you can incentivize by going back to what worked before. And what worked before, and what kept all those immigrant populations of the 40s and 50s healthy, was access to their community pharmacist who is there every day because they own their practice. That's gone. That's gone in the physician world. The idea of in our area was the old Jewish physician, Dr. Blinn, would show up, open up at 7 o'clock in the morning, and he would stay there till 7 p.m. until the last person was seen. That doesn't exist. All the physicians' practices are owned by health systems now, and it's just employees that go through. But we can bring that back in pharmacy. And guess what, Todd? People want it. Mm-hmm. People want it. People always bemoan the loss of a community pharmacy. Not so much with I liken what we're going through to how bookstores got wiped out in the 90s, and then it was all Borders and Barnes and Noble and blah, blah, blah. Now they're gone because of Amazon. Mm-hmm. And then everybody yearns and goes to these old bookstores, the ones that survived, and now new ones open. Yeah. We're also seeing it like with records and things like that. We see these cycles through markets, and I think 2025 is the year that if New Jersey can step forward and show the courage to follow the other states that have done this and save their taxpayers hundreds of millions of dollars, you are taking care of your most vulnerable. You're saving, and when I say saving hundreds of millions of dollars, that's the drug spend, saving hundreds of millions of dollars. We're not even analyzing the data and the metrics of how much is saved by that person who had, congestion because of dry air in the wintertime, going to the emergency room, being charged, or the health plan or the government, if it's Medicaid, being charged $1,500 for an emergency room visit, and the patient comes out with a prescription for saline.
Yeah.
That's the value of the community pharmacist. So initially, at the outset, I think that we demonstrate cost effectiveness and cost savings just on the drug spend. That's what the PBMs don't want you to know. They don't want you to see the effective spread pricing, that they pay us 75 cents for 30 Norvasc, but they're charging the state $75.
Yep.
That's what they don't want you to see, but that's what's been seen. Yep. And there's algorithms now that these states have used that demonstrate that. Ohio did it. Arkansas has done it. I believe New York has done it. California has done it. Hopefully New Jersey will be the next one to do it. And not only that, and what I always say to our legislators is, you are going to solve multiple problems and not have to raise taxes to do it. If I came to you and said, you could put a program in place that would save the taxpayers money, it's going to be a net positive. Mm-hmm. It's going to spur redevelopment in inner cities. It's going to expand access to vulnerable communities. Yep. And those pharmacies will pay tens of thousands of dollars a year back to the state in taxes for employees, for FICA, Medicare, all that, when many people kind of forget this, but a business pays a lot of taxes outside of its property tax. I always say, and my solution to America's manufacturing crisis, and I think the once and former president must have been listening to me. I said that if we were smart, we would charge companies nothing if they manufacture here. You know why? You're no more unemployment. Mm-hmm. The taxes that are paid, it's not corporate tax. That's negligible, really. But it's all the other taxes that are paid when you maintain employees. Mm-hmm. That's where communities, the government, everybody benefits through small business employment. And it also helps groom and expose the next generation of pharmacists to pharmacy.
Yeah.
I never had any intention of being a pharmacist. I'm horrible in science and math, but I went into a pharmacy one day because I needed a Saturday job. My grandfather took me there, and it changed my whole perspective. Mm-hmm. And I wanted to be in the business of pharmacy. How is the next me being exposed to that moment when that doesn't exist anymore? We do mentorship programs with school districts to expose kids to what it's like to run a pharmacy, in the hopes that they like it, and they're hopefully one of the entrepreneurs that opens up and serves neighborhoods in the inner city. And this is something that isn't just a Camden, New Jersey problem, or as I hate to use the term, but that's what people call it, a community of color problem. This happens throughout the country in our rural areas, and it's now even spreading to our suburban areas, because chain stores can't stay open on prescriptions anymore. Who goes to, if you want to get a roll of toilet paper, you're going to go to a convenience store or call Amazon. They bring it to you faster than if you made the trip yourself. So we need to get back to the community health hubs that were pharmacy. And it's so easy to do. And you don't even have to pay, Todd. We're talking about payment for services, and that's all great. All you have to do is pay pharmacists fairly for the job they already do. And we already continue to give away our advice and our knowledge and our guidance for free. Mm-hmm. It doesn't have to be nearly as complicated. Good practice, good business, retaining patients, developing relationships, that builds a practice. It builds revenue. It builds stability. Yep. And it keeps the patients outside of the emergency room and urgent cares and everywhere else. And it's a win-win-win. Patients love it. Pharmacists like myself will definitely love it. You don't worry about how am I going to turn on the lights the next day, and you're taking care of your most vulnerable in a sustainable fashion. You don't have to worry about additional costs. The first thing everybody's going to say is, "Oh, okay, well, pharmacists want to get paid. Well, where's that money coming from?"
Right.
So what we saw with the vaccines. Todd, I'll be honest with you. When the COVID vaccine was coming out, we were going to do it because we anticipated the need at that moment in our community for COVID vaccines. Somebody who voted for number 45, I was not all that pleased with his $13 and then $13 for the booster administration fees. I much preferred the now, I guess, nearly former president Joe Biden's $40 a vaccine. But I know a lot of people who weren't going to do the COVID vaccine until it was $40. Then they did because it made financial sense. Mm-hmm. And what that did was it saved the COVID vaccine effort at the time, which had failed. It had failed. The government couldn't do it at its government-operated centers. The chains, though they had the infrastructure, couldn't do it because they had one set model that was employed throughout the country, and that never works. Independent community pharmacies saved the vaccine effort at the time. And that right there that's the model. They didn't have to pay us extra for it. They paid us fairly. And if you pay, a good business person or a good practitioner fairly, they're going to be able to build the rest around it and add more services to try to pull more patients in. There was an old model way back. The first, what was then called an HMO, was back in. It was called U.S. Healthcare, mm-hmm. And their model was based on something completely different. They gave you what was called a capitated payment, which meant if you had 500 patients, they would pay you $35 per patient per month, and that's it. That covered everything you had to do with them. Mm-hmm. And pharmacists at the time looked at this as, oh, that's a great idea, until they saw what happened and how expensive medicine can get. And then they had to start putting in, different mechanisms to pay people above the capitated rate, which was a whole other bureaucracy. But very few pharmacies wanted to carry U.S. healthcare at the time. And it was a concept that was developed by a fellow Philadelphia College of Pharmacy and Sciences grad of mine. But, it was a model that didn't work because the financial model, the incentive didn't work because we're still product-based. Mm-hmm. But if you, in this model, it made less sense to have more people and to do more service. You want to keep them the hell out. The best idea under a capitated model is to close the door the whole time and just keep the money. You don't want to expand services and hours and everything else because every time the patient comes in, it's a loss. So I get the concept was a good concept. It doesn't work in pharmacy very well. But again, the idea is when you go to a fair compensation model, the business will follow with it. And the improvements and the innovations and programs in healthcare for these communities will also follow. So the government doesn't have to do it. The government has to create the environment to allow us to be able to do what we need to do as entrepreneurs, as practitioners. A lot of people in healthcare will think that that's a dirty word. That's terrible. You're not a business person. You're a pharmacist. No. All medicine's business. Medicine's business. You have to be able to succeed in business to have a successful practice, and the two feed off of one another. Good practice is good business, and good business allows you to improve your practice. And it's something that has resulted in individuals of another generation walking in their pharmacy when they were young graduates like myself, and then life goes by and suddenly they're 93 years old and they're still in the exact same place, talking to the exact same patients but their grandkids and their children and others that moved in. That's the dream. That's what's special about pharmacy. That's why pharmacy and independent pharmacy endures. People want that. People want that connection. And until we reform the model of how we reimburse pharmacists, it's never going to work. And remember something, for all the, as much as I admire what TruePill does and what Amazon does, they didn't vaccinate one single person. They didn't prevent one single visit to an emergency room. Likewise, when somebody comes in and they're feverish and sweating and sick and they just want some Tylenol, nobody's checking to say, wait a minute, you need to go to the doctor. And people will just take something over the counter, they'll get it at their gas station or Wawa or wherever, they'll go home and then they wind up sicker. Then they wind up in the emergency room. It's all those interventions that we've lost. And until we get to a point where we allow that dynamic to reform in these inner cities, are we going to be able to demonstrate the metrics? For us, it's not demonstrating cost effectiveness before. We'll be able to say, oh my God, how much money did we waste all those years? Look at the difference when you have easy, walkable access to a community pharmacist that knows the community he's serving and the people who are his patients. So that couple dollars, all that money now sits with the PBMs. All those billions of dollars are paid out in dividends. They go into, shareholder returns and buybacks and these big conglomerates. That's doing good for some. Maybe it does good for my 401k. I'm sure I'm invested in United Health as poorly as they treat me, but that's not what's going to drive better health outcomes and more efficient, inexpensive healthcare. And that's where I see the big battlefield for 2025 is fighting for pharmacy to be given that chance again. And as I said, we demonstrated something special during the COVID vaccination effort. I keep reminding people over and over, don't ever let that be forgotten. We were the heroes, though unsung, of COVID, of that time. We were here every day. Not everybody was. We didn't get to sit home in our, in our offices or in our basements. We as pharmacists have to continue to remind people we are the most cost-effective way to better health and to less costs. And, that's what it's all about. We just have to be able to show that. Fortunately, through the work of Antonio and through the work of so many more who have exposed the PBM cartel for what it is, to those who show what's happened with pharmacy deserts. Nobody cared about what that was. Pharmacy deserts was a term somebody at CNN made up, talking about something they saw in Chicago 2 or 3 years ago. That's been around for a while, and it's not a Chicago problem, and it's not an inner city problem. It's now become a national problem and a national crisis. And the time is now to take these aggressive steps to start creating the environment for us to fix this problem. And guess what? If you give pharmacists the ability to fix a problem, something that I know about us, we fix it.
Yeah.
And we fix it quickly. And that is, I guess that would be my strongest message, my end of year message for everybody as we wrap up 2024 and look at 2025. Again, things are happening and we are in a historic time for our profession. I keep saying that over and over again. We are going to look back at this 5 to 7 year period that we've had post-COVID and what we've done after. And everybody is going to see that's where the greatest comeback story, the greatest turnaround happened.
Yep.
And we've got it, but we got to keep working. I've never seen movement in this profession like we've seen. I never thought I would ever see the day where fee for service would ever come back.
Yeah.
Much less that we would be able to show how much less expensive it is and how much better it is for everybody except the PBM. It's an exciting time, but the PBMs aren't giving up. And we have to make sure that we don't give up. And the next golden age of pharmacy has already started. We just don't recognize it yet, but we will.
Tony Minniti with Camden Apothecary out of New Jersey. It's a wonderful time to constantly connect with you. You have to promise that you're going to be coming back throughout 2025. We want to pick your brain about a bunch of things. One of the things is the expansion of cannabis as therapy supplement and possibly a replacement in some cases, depending on the outcome and what the disease state is. But we want your insight on that. So promise you'll come back.
Definitely will. I've already developed the model. The model's out there. So getting it out there to everyone and hoping that pharmacy embraces it. I'm excited for that. I can tell you that professional organizations haven't come around just yet. I'm hopeful, but this is something that is largely hands off with all the professional organizations. I can't even get the model published. Not even as an op-ed. But you know what? Sometimes that happens. You have to turn those that don't believe into believers somehow. I've done more difficult things, but I think that the time is right for this. We're seeing, really this conversation has been elevated with all the talk of rescheduling and descheduling and how that all works. I'm optimistically hopeful that the new administration will hear what I have to say on this. Mm-hmm. I think I could be able to get an ear there. So that's exciting to be able to really discuss this in a fashion, especially with the rescheduling versus descheduling being front and center. But we as pharmacists need to activate, and I will give that call to action to all my fellow pharmacists. We need to, as a profession, activate. The nurses are already mobilized. Yeah. And if we don't establish ourselves and pharmacy's place, we're going to wind up left behind, just like we were with certified nurse practitioners and physician assistants and all those who are inarguably less qualified to prescribe than we are. They all have prescriptive authority, yet we still don't. Yeah. That's because we didn't act back in the 90s, back in the 80s, when this was starting, when this was on the horizon and nurses were looking to be able to advance their degrees and be able to get prescriptive authority. Physician's assistants, that's all there. We're more educated, we're more qualified, we're more capable. But because we're not organized and we don't stand up and say, this is we belong to, we lose that opportunity. And we're dangerously close to losing that in pharmacy with cannabis, because too many pharmacists have taken the idea of, they don't want to accept the fact that there might be a medical benefit to this. They don't want to look at it as anything other than it's an illegal Schedule I drug. There's some that do. Alan O, he does. There's plenty of pioneering pharmacists that look at cannabis and see the potential and the benefit. But the nurses, they are already firmly entrenching themselves in this. So there will always be a medical component to cannabis, recreational or otherwise. There will always be a medical component to cannabis. Our only question is, will pharmacists be part of that component, or are we going to sit on the sidelines and let the other allied healthcare professions take our place? And I keep pressing, but it would be great if NCPA and APHA and so many of the other organizations were more embracing of this. It's great to see that the pharmacy schools are offering courses and training such that they can in this. But for all those independent pharmacists that are wondering, how do I stay in business until fee-for-service comes? Think about cannabis. Yep. And think about how you have that ability to be a true medical practitioner without having to answer to a doctor, without having to answer to the FDA. You can guide, organic, herbal, alternative therapies, not unlike chamomile or turmeric or cinnamon or ginseng or anything else. Think of it that way. And the same way we as pharmacists always make those recommendations for over-the-counter supplements in that fashion, that's the same way we should be doing that with cannabis too. It takes creativity, it takes a little drive, a lot of work, but I can tell you it has been one of the most fulfilling and exciting things that I've been a part of. And every time I think I've seen and done it all in pharmacy, something pops up that surprises me. And Todd, including the Pharmacy Podcast Network. Again, as I always like to end with, thank you. Thank you for what you've done, for your continued efforts in sticking with building this for us. I always say, this is stuff that I would holler at the steering wheel on my way home in the car, or commiserate with over several pitchers of beer with my other fellow burnt out pharmacist friends in the late 1990s about, woe is me. But we can actually come on here and have our voices heard. And, it was so important when you did it way back with, God, how long ago does it seem now, with Dr. Tanui, and, pizza is not working. She had that, that Jerry Maguire moment. Yeah. And you amplified her voice, and she changed the whole conversation about community pharmacy and did so much of this and got it started. So again, as always, thank you so much for this. As I always recommend the Pharmacy Podcast Network to friends and colleagues alike. And what we as pharmacists need to start doing is we need to start advertising among our networks, not to pharmacists who probably already know, but to the other healthcare professionals that we associate with, about the specialized programming that does have a lot of value to our friends who are PAs, nurse practitioners, who are in some of the related fields, to our pharmacy technicians, to our physician friends. Believe it or not, physicians these days are very open to recommendations from pharmacists regarding all things medication. We should be recommending this forum, these podcasts, likewise, to our colleague physician friends, and let them know, hey, you can get some great information, some great insight that could help you in your daily practice by listening and subscribing. So I would encourage everyone to, you've been so supportive of our profession, Todd. We need to now take on supporting and helping you grow for all the sacrifice you've made for our voices to be heard. So to all out there, Pharmacy Podcast Network, you have to like and subscribe. I'm assuming if you're listening, you already do. Get one friend too. If everybody that listens got one friend to do this, we would double our listens, and that just amplifies our voices even more. So, Todd, again, thank you, and hopefully I'll talk to you before 2025. If not, I'm sure I'll talk your ear off for another hour then too.
I love it. I love it. And you're absolutely right. This is the Pharmacy Professions podcast platform. Any pharmacist that's credible and has something to amplify and talk about. Pharmacy technicians too. Shout out to you. And if we can teach our other healthcare providers what's really happening and what we're struggling with and how we want to help more and how the industry is transforming, I think it'll help us accelerate. And like I always say, together RX, we're in this together RX, and we are. And there's more work to do. But thank you so much. Thank you, listeners, for listening in to this conversation with Tony Minniti. You can find him on LinkedIn. His last name is spelled Minniti. That's Minniti. Tony, this has been wonderful. Thank you so much. We will talk to you next time on This Week in Pharmacy.
Thanks so much, Todd. Looking forward to it.